Hello, this is David, and the topic today will be the type of ultrasound and particularly Doppler flow parameters that are used to follow a pregnancy. And we'll see or contemplate how these could potentially be related to placental pathology. So I entitled it Can Sonographic Parameters for Following IUGR? Because that's really a main problem. Can sonographic feature parameters for following IUGR be mathematically modeled, and will this give us a better understanding of pathological states of placental growth? So, one of the greatest problems, or one of the greatest challenges in maternal fetal medicine, is the problem of intrauterine growth restriction or delayed growth. And when a patient experiences this, or when the fetus experiences this, there's usually a trajectory that the patient goes through and various tests. So let's say, for example, and also before I say that, I should just say that IUGR can probably be divided into, well, it could be divided in many ways. People have attempted to divide it symmetric versus asymmetric. And another way that clinicians divide IUGR is early onset, which is a rather severe form of IUGR, and late onset IUGR, which is a more mild form of IUGR. And so if we take the early onset IUGR, and let's say a patient has an anatomical ultrasound at approximately 20 weeks gestational age, and the ultrasound shows that the growth parameters for the baby are slightly behind. Then the question becomes, how can you further follow this pregnancy? And also, when and if you follow the pregnancy and confirm that there's intrauterine growth restriction, at what point does the risk of preterm delivery, at what point is that offset by the risk of leaving the baby in that depleted environment? And so that's one of the arts of obstetrics. To sort of, number one, determine which patients with IUGR have not a constitutionally small baby, but a true baby that's affected by an insufficiency problem. So that needs to be determined. And then further, to make the determination when the risk of intrauterine deprivation is so great that it offsets the risk of preterm delivery and it's time for the baby to have to come out by induction or some form of intervention, including a cesarean section. So let's first just discuss the ways that an ultrasound or that various blood flows could be monitored in the instance of a pregnancy. So just this very rough schematic, we see here a uterus. So here's the uterus, here's the cervix, and the uterus is supplied by the uterine arteries, which directly branch off the internal iliac vessels of the mother. And that supplies the placental bed. This will be the maternal supply. And the fetus is sitting inside the uterus and has the placenta, and the fetus umbilical artery hooks up to the placenta, and this is the fetal circulation. So what the pathologist often doesn't see is that the clinician has access to monitoring often both circulations, and almost counterintuitively, the circulation that gets monitored more is often the fetal circulation. Whereas, what we usually blame as a primary etiogenic or etiological event is we usually say it's maternal undersupply to the placenta that causes everything. But the parameters that usually ultimately necessitate action are fetal flow parameters. And this would be relatively routine information to an obstetrician, but sometimes pathologists don't, this isn't really the realm that we dwell in. So it turns out that these circulations can all be measured. So the uterine arteries can be subjected to Doppler flow assessment. And if, for example, there's a suspicion of IUGR in the first trimester, so I wrote here the maternal parameters, so the uterine artery could be followed by a Doppler. And if one is doing uterine artery Dopplers in the first trimester, and I'm not going to get into too much detail here. I'm not a sonographer. I'm not a radiologist. The feature that sometimes tips you off that sometimes that there could be something wrong with the gestation is what's called an increased pulsatility index in the uterine artery, and also increased resistance. And sort of a crude way of sort of understanding it is that the heart has a cycle, and when the pump is pumping, it's in systole, and then between pumps, it's in diastole. So if this would be zero flow, there's sort of a peak flow that comes up during systole, and then the flow goes down, but there still does continue to flow during diastole, and then you have another systole. But the ratio to the maximal flow in diastole and the maximal flow in systole is the systolic to diastolic ratio. And my crude understanding is that the systolic to diastolic ratio is an index of how high the resistance is within the maternal arterial circulation to the placenta. And so the greater the systolic to diastolic ratio, and that gets calculated by the software into something called the pulsatility index, the index of the pulse, the difference between here and here, the pulsatility index. And that gives you a sense of the resistance. And in addition, the resistance can be directly measured. And the resistance and the pulsatility index within the maternal circulation, even in the first trimester, is a marker of the fact that the fetus could develop ultimate IUGR. It suggests early on that something's wrong in the maternal circulation that's trying to supply the placenta, and this baby and this placenta could then be at risk for downstream consequences such as IUGR. And this is one of the first things that are noticed, is changes in the maternal uterine artery circulation. The next thing, so if one is doing uterine artery following in the first trimester, one looks at the pulsatility index. If you're doing it in the second trimester, there's a feature, there's some kind of a notch. There's some kind of a notch that you actually see. That is a relatively sensitive and specific, to my understanding, for the development of preeclampsia. But that notching is really seen mainly in the second trimester. It's not so reliable in the first trimester. But the maternal fetal medicine doctor or the obstetrician who's performing the sonography can see this systolic to diastolic ratio or this notching, and can predict that this baby who's small, because in the ultrasound, you look at various parameters. You look at the head circumference, you look at the femur length, and the baby, let's say by biometry, the measurements of the baby are called biometry, is found to be small. But then the question always is this a constitutionally small baby, or is this a baby who's being growth restricted due to a depleted environment? That, in a way, is a million-dollar question. And if you have problems with the uterine circulation, either increased pulsatility index or notching, that suggests that there's a problem. There's a problem with a circulatory interface between mother and fetus, and there's going to be true pathology, and this baby needs to be monitored very, very carefully, because there's a high risk of all sorts of complications, including intrauterine demise. But there's also parameters that the doctors can follow in the fetal circulation. And my understanding is that these start to appear slightly later than the problems in the maternal circulation. And while the problems in the maternal circulation are relatively good flags that IUGR might be developed, so that they're sort of flags that this is going to be IUGR, problems in the fetal circulation are more dire. And when you start to see problems in the fetal circulation, depending on what the problem is, it moves more and more toward the suggestion that, hey, something could really be wrong here. The fetus could be at imminent risk. Maybe this fetus needs to come out. And so one place that the fetal circulation could be monitored is the umbilical artery. And in fact, it's relatively routine to do umbilical artery Dopplers. And it's important for the pathologist to realize that although we ascribe often the primary event that causes preeclampsia, a form of placental insufficiency, so insufficient maternal supply, often, especially in later, well, let's say 20 weeks and on, the parameter that makes the obstetricians really react are umbilical artery. So they're looking at the fetal circulation. They're looking at the fetal, if you will, and this is to oversimplify, they're looking at the fetal consequences of the maternal insufficiency. And one of the things that they follow is the umbilical artery pulse. So if we imagine the placenta here's the placenta, so let's look at it. Here's the umbilical cord coming out of the fetus, and here are the chorionic vessels ramifying onto chorionic plate. And actually, it would probably be better even to draw the blood as blue, because as you know, umbilical artery blood, like pulmonary circulation blood, is deoxygenated and sort of ramifies on the placental surface. And you could use your Dopplers to get a measure of the pulsatility. And so once again, it's similar in a way to the uterine arteries, because it's an arterial pulse. You have your zero level, but then you have your systolic and your diastolic. And your difference between your systolic and your diastolic is calculated by your software into your pulsatility index. And that could also be determine a resistance value. And once again, the greater your pulsatility index and the greater your resistance, it starts to suggest that there's a problem. So that's the first thing, is that you start to get, the first thing that you start to get is an increased pulsatility index and increased resistance now in the fetal circulation. And that could progress even to something worse. You could start to see, number one, you could start to see problems in the diastolic flow, where the diastolic flow really tapers off. And in the worst case scenario, the diastolic flow could actually move in the opposite direction, suggesting that blood is, during part of the cycle, actually, most of the time the blood is going this way, but during a tiny portion of the cardiac cycle, blood is actually sloshing backwards. And that's, and the term that they use is abnormalities of end diastolic flow, and the serious term here is reverse end diastolic flow. And when an obstetrician sees reverse end diastolic flow in the fetal circulation, that suggests, in a way, I'll oversimplify, that the resistance is so high in the fetal circulation that basically all the forward momentum, all the forward flow is spent during a certain part of diastole, and come the end of diastole, blood is actually sloshing backwards. And so, with that, I think I'm going to end this installment, and I'm going to continue ideas about how this could potentially be further modeled in a second installment.